I was in the audience a few seconds ago and I kept thinking this podium was too large for me because I am a short gal. So I want to welcome you all to this amazing experience. I know I've had a lot of interesting conversations with so many people, and I hope you have too. Hello. I know that we had a few laughs, and you know nothing about me, and I know nothing about you. So let me tell you a little bit about myself. I'm Sophia Legatuda. I'm a 10th grader at Mission College Prep up in SLO. I did drive 2 hours to get here, and so did you. We are here to talk about youth mental health, and I am so happy to be able to welcome you all. I am a AIM Youth Ambassador, and I'm honored to be able to introduce our three wonderful speakers, Dr. Bucci, Dr. Thakur, and Dr. Long. Their expertise is truly shown through their experience. For example, Dr. Monica Bucci is the Director of Research at the Center of Youth Wellness in San Francisco and an author of a scientific research on how our brain and body respond to stress. While Dr. Neeta Thakur is an associate professor at the University of California, San Francisco. Her research program focuses on the short and long-term health effects of our multi-level stressors, with emphasis in historically marginalized populations. Last but not least, Dr. Dayna Long is a pediatrician with a special interest in community health and engagement, and in promoting equality in healthcare. Her goal is to enable all children to be as healthy as possible by eliminating the inequalities that lead to poor health outcomes. Let's give a round of applause to Dr. Bucci, Dr. Thakur, and Dr. Long.
Hello, everyone. Closer? Here? Good? I would like to start by thanking Lori Butterworth and AIM for this opportunity to come together to tell you the story of our research journey. The Monterey Peninsula has become my home about 3 years ago, and I'm the mom of a 4-year-old boy. So as a mother and as a researcher, I'm extremely grateful for the act of service that AIM carries out to protect and support our youth in the peninsula. I'm also grateful to my wonderful colleagues, Dr. Neeta Thakur and Dr. Dayna Long, who welcomed this opportunity to share with you today our journey with so much grace and enthusiasm, the same grace and dedication that I've witnessed during the almost 8-year-long journey of our study. As I was reviewing this presentation last night, I was reminded of all the learnings, at times very painful ones, that we experienced together. And my greatest gratitude goes to the youth and their caregivers who allowed us to look closer into an issue that represents such a critical public health threat for our society. And while we were the first to conduct a longitudinal study on how trauma and adversities affect the health and well-being of children, we were not the first to look into this problem. We were standing on the shoulders of giants. In fact, I think I have to move this here. The term adverse childhood experiences comes from the landmark study conducted by CDC and Kaiser Permanente and led by Dr. Felitti and Dr. Anda in 1998. ACEs described 10 categories of adversities in 3 domains experienced by the age of 18. Either abuse, physical, emotional, or sexual, neglect, physical or emotional, and household challenges, like growing up in a household challenged by mental illness, substance abuse, parental separation or divorce, incarceration, or intimate partner violence. These ACEs are very stressful events, and the ACE studies show that when experiencing childhood, they are associated with increased likelihood of poor long health outcomes, depression, substance dependence, and even early death. Although some stress is actually positive and adaptive for children, when a child experiences long-term and severe stress, such as that comes from exposure to ACEs, in the absence of a nurturing adult, the long-term activation of the child's stress response and the consequent overexposure to cortisol and other stress hormones that follows can disrupt and dysregulate their stress response. This state has been defined as toxic stress by the National Scientific Council on the Developing Child in 2005. Although I think, I can't see.
Oh, it's right there on the
Here.
podium.
Okay, here we are. Scientists now understand that the dysregulation of the physiological stress response that follows the exposure to stress and ACEs plays an important role in the clinical progression to negative long-term health outcomes, not only in childhood, but over the lifespan. And moreover, research is showing that ACEs frequently co-occur. So being exposed to multiple ACEs becomes a major risk factor for many physical and mental health conditions like depression, suicide, mental illness, substance abuse, learning and behavioral difficulties, asthma, obesity, diabetes. Basically, 7 out of 10 of the leading causes of death in the United States. So it becomes imperative when addressing public health improvements to adopt a psychosocial model that includes prevention of ACEs, resiliency building, and ACE-informed provision of services in order to reduce ACEs and their life course effects on health. In 2012, the American Academy of Pediatrics called on pediatricians to actively screen the precipitants of toxic stress that are common in their particular practices. As we know, pediatricians and primary care providers witness the manifestations of toxic stress daily while working with children. However, pediatricians did not feel equipped to intervene in this crucial dimension of health, and they were faced with big challenges, such as the absence of a validated screener that was age-appropriate for children. And even when ACEs were identified, there were no known combination of biomarkers and clinical data to help the pediatrician discern which children were at risk of toxic stress. And more importantly, there were no evidence-based interventions for reducing the risk of negative health outcomes associated with ACEs and toxic stress, which, as you can imagine, posed a real ethical struggle for pediatricians when screening for ACEs in children. To address these gaps and to produce valid and reliable clinical guidelines for pediatricians, in 2015, we created the Bay Area Regional Consortium on Toxic Stress and Health. We set 3 aims for our work: to validate a pediatric ACE screener that was scalable for universal screening in pediatric and primary care settings, to estimate the associations between ACEs and biomarkers of stress in children, and finally, to evaluate whether evidence-based interventions for children at risk of toxic stress could lead to changes in their stress physiology. The BARC was a partnership between UCSF Children's Oakland, Benioff Children's Oakland, UCSF School of Medicine, and the Center for Youth Wellness in San Francisco. And this is our last picture together at the end of our study in 2019, when our champion, Dr. Nadine Burke-Harris, had been appointed as California Surgeon General. I will now pass the baton to Dr. Neeta Thakur, who will take you along our research journey and our findings, and then to Dr. Dayna Long, who will showcase how we implemented our findings to make pediatric clinical practice in California really ACEs informed.
Thank you, Monica. I'm standing after a 2.5-hour drive from San Francisco. I need to be sitting for a little bit. But I'm very excited to share some of the work that we've done collaboratively across communities and academia, and also with our families and our clinics that we serve. And so the 3 things I'll be going through that really form the foundation for our main study is trying to first understand, is it even feasible to screen and address ACEs in primary care? What should we be telling families and patients about ACEs, and what does that mean for their health when we're in primary care? And then, if we're going to be screening, we need to be doing something about it, right? You can't screen without resources. You can't screen without having some sort of intervention. So what does that intervention look like when we know it is so hard to access resources in the community? Is there something we can do in primary care? And then the last part is our larger study, which is called PEARLS, which was a randomized control trial of screening, and then also a pilot of different interventions that could be implemented within the context of primary care to support families. So the Pediatric Resilience and ACEs study started in 2017. And we knew at the time there was loud, clear calls that ACEs were important for health. But what we didn't know is, what did families want in primary care? How do they want to be asked about ACEs? And what does it look like when you ask families about ACEs? What do they actually share with you? You know that it's very sensitive information, and whether or not they would be willing to disclose in a healthcare setting was a big unknown. We wanted to also understand if there were specific characteristics or demographics that were associated with not disclosing if you asked in different formats. And then lastly, we wanted to understand, we're asking about these ACEs, and we know that they're associated with poor health outcomes in adulthood, but when do we start seeing those associations in kids? As an adult care provider, I'd like to think that 0 to 3 is not the only age that we can intervene with families to break the cycle, but there's multiple time points across someone's life course where we can intervene and support families and the child to allow them to thrive into young, healthy adults. And so to develop our screen, we took several different steps. First, we wanted to take a scoping review of all of the available screens that were out there at the time. We also thought it was really important to get the input from our families. So asking them not just, hey, are these questions okay to ask, but also, how do you want to be asked? Do you want to be asked in a private room? Is this something that we can give in the waiting room? Is it okay to give it on a tablet? Would you rather have a pen and paper to fill out the survey? Do you want to say, of all of the items on this sheet, how many in total have you experienced? Or do you want to say, I experienced this, I experienced this, as I experienced this? We wanted to get that level of specificity because we knew if we were going to implement this widely across primary care practice, we better be doing it the way families want it to be done. We also wanted to ask, what do you want if we screen you? What is your expectation from us as the healthcare system if we're asking you about these questions? And then lastly, we knew that asking patients and families about ACEs could potentially be triggering. But we also knew that for our staff and our providers, in seeing these items and having these conversations with their families could be triggering from themselves, either through experiencing their patient's trauma or through reliving their own trauma. So we wanted to be sure that appropriate training was created when going about this process. So where did we do this? So we did this at Benioff Children's Hospital, Oakland, which is a federally qualified health center in Oakland, California. 90% of our families are from communities of color and identify as Black or Latino. 90% live at or below the federal poverty line. And the children that we included in the study were those that were 3 months to 11 years of age coming in for the well child's check. We had the caregivers be 18 years and older. The primary caregiver, we weren't expecting them to be a biologic parent because we know that that's not always what a family looks like. And we also needed them to be able to speak Spanish or English and receiving primary care at that center as opposed of coming through urgent care, because we knew if we were going to screen about trauma, we better have a way to follow up with them regularly within our clinic. So the screening tool that resulted was the Pediatric ACEs and Related Life Event Screener. So this includes the 3 original domains of the ACEs screener that Monica shared with you before, with the 10 same categories. And then we added a 4th domain for related life events, which included things like food insecurity, housing instability, discrimination, and experiences of community violence, knowing that these things were prevalent and that a separate body of literature had shown them to be operating similarly and being associated with worse health outcomes in adulthood. And so this came about, and this is the PEARLS tool that we used in our larger PEARLS study. And so what did we do? So one of our questions was, if if you were to screen someone and offer them anticipatory guidance, how would that look if you didn't screen anybody at all long-term for their health effects? So that was one question: is screening and a mild light touch intervention useful or not useful? I will say we're still figuring out the results of that one because that's going to take a long time of follow-up, and we're actually in year 5 of follow-up of our Pearls children, so to be determined. The second was, what do disclosure rates look like if you ask them in an item by item, have you experienced this, have you experienced this, have you experienced this, versus asking, hey, of all of these things, how many have you experienced? And so we randomized our families to receive one of the 3 formats. So no screening, asking about it in aggregate, or asking them about it in item level. And so after we screened them, we had a mental health provider meet with the families and ask them what they thought about the experience, and how did they feel about being asked about these different things, and then also go through with the families that received the format in aggregate form, go ahead and identify which items that they have experienced. And so this is some of the results from our study. It's kind of hard to see on the screen up here, but what I can tell you is that 76% of our children and family reported at least one adversity, with 39% reporting 4 or more pearls. And then with the most common adversity being reported was experiences of domestic violence in the home. By format, the Pearls disclosure rates were significantly higher in those that were asked about it in total form. So how many of all of these things have you experienced? Versus for those that were asked item by item. And that averaged about 1 more disclosure compared to being asked in the item level. And then we noticed that the disclosure rates differed. If you were a child who identified as Black or as a boy, then your disclosure rate was actually lower in the item level response compared to the aggregate level response. And I think that reflects on a lot of different things that we've talked about as a group, and one of them has to do with trust. And it was a theme that came out in our qualitative work and our interviews with their families about maybe why there's differences in response rates based on the way you ask. And so we also asked about preferences. So despite us seeing that people disclosed more when you asked about it in aggregate as opposed to one item at a time, the preference per families was that they wanted the item level report because they thought it was important for their provider, not necessarily the health system, but their provider to know what they're experiencing. And with 12% expressing a preference for the aggregate level format. And so what we learned when we talked with our families after we did the screening formats, what we found is that if you're going to ask, there's some expectations that our families have with that screening tool. So you need to be clear about what will happen with the survey results if you're going to be screening in clinic. And you should have some sort of workflow of referring patients or offering resources for families that do have significant results, and also have some baseline universal education available to give for them. We also found out that the quality of the provider-patient relationship, and this is not surprising, really dictated how comfortable the individual family member felt in completing the report. And so you can see this playing out, that if you don't have a good relationship with the provider or the health system that you're part of, you just may not disclose anything because you're not having that trusted relationship be the basis of the communication. And then lastly, there was some things about how people felt about having the survey done, and most of them, they had a positive response, but there was a few that had a negative response from the survey. And so what we found in the children that were experiencing ACEs and that they were screened, compared to children that weren't experiencing any of the reported Pearls items, we found that those where they had a poorer perceived health. So we asked a couple questions about how would you feel your overall health is. And those that experienced one or more pearls reported more perceptions of having poorer health. We also found that for children that had higher levels of pearls, that there was a connection with their ability to do executive function tasks. And so there's a tool called Brief, where we kind of get an idea of the development of the child on how to be able to do high executive function. And if you were experiencing pearls, your scores on average were lower than those kids that reported no pearls. They were also more likely to experience some somatic symptoms like stomach aches. And then what we also saw, which has been shown by others, is that there was an association with allergic type diseases such as asthma and eczema. Here, I wanted to share some of the results that we saw with looking at perceived stress, and then also with poor reports of health. And so the top line up here in the black circles, and so the lower the score means the lower your self-rated health is, or the caregiver's report of the child's health is. And what you can see as you move from reporting no ACEs, or no pearls, compared to those that have 4 or more, here you're seeing that trend that you're perceiving your child to have worse health. And similarly, the caregiver with more reports of ACEs in the household or with their child, they perceive to be more stressed. And so this starts to get to this, there's a connection between the caregiver's stress levels are getting carried over into the child's perceived health. And so that's an important thing that we've been really building off of in our intervention trials, in kind of thinking about that caregiver-child relationship, or a positive role model or positive adult in the person's life. And then the last thing, we talked a lot earlier about how ACEs are associated with negative health outcomes in adulthood. And here we're able to start showing that that is starting in childhood. And we're seeing this very strong association between increasing reports of pearls and increasing likelihood of having asthma. And then we just submitted another study that even showed among kids that have asthma, if you have increasing reports of pearls, your asthma is worse controlled despite being on appropriate medication. And so that's an important stressor that we're not addressing in routine clinical practice that we need to be thinking more holistically about. And then as part of this larger pearl study, we wanted to have an understanding of what are the different types of interventions we can offer realistically within a primary care setting. So one of the interventions, which I'm not talking about here, was called Find Connect, which is a community resource navigation. So you ask families about what sort of needs do they have right now, and then you do warm connections to those resources in the community. And so what that could look like, a family could come in and say, like, I don't have food right now in our house. Then that navigator would say, okay, well, this place has a grocery bag pickup that you can do on these X, Y, and Z days, so they can go get groceries that day, and then enroll them in WIC so that they can have a more regular supply of food in the household. And so that's one example of a resource navigation program that has been successful in improving health outcomes in children in general, and we were trying to use that as one way of supporting families that have high pearls. The second is through this resilience clinic, which gets at this caregiver-child relationship. If we can build a positive relationship and help develop those resilience skills or those self-regulation skills, would that change outcomes for the child? And so this was based on an evidence-based intervention called Circle for Security. We met weekly with families in a group setting and used a lot of art therapy and imagery to help explain the ideas, and then also provided skills on positive parenting for the caregivers. And what we found is that their suggestion, because this was a very small study, so not large numbers here that I'm going to be showing here, but what we found is that in those caregivers that went through this program compared to caregivers that didn't, we saw that their overall stress levels trended towards being less stressed. compared to those that didn't go through it. We also saw small improvements in the executive function of those children as well. So we are now in a process of trialing this in a larger study to see if this is something that could be offered as an intervention for families. And so I'm hoping through this brief talk through some of the research behind the PEARLS tool, but also behind ACEs, we've at least provided a rationale why screening for ACEs or for PEARLS is important for primary care. And then also have just demonstrated a tool that can be effectively used in primary care that was co-developed or co-informed by families in our clinics. And then hopefully, as we go forward, we'll be able to show larger impacts on like what this means for health outcomes avoided in families, and also, helping families and children thrive in the community that they are. I'm going to pass it on to my colleague, Dr. Long, to close this out this afternoon.
Thank you, Neeta. This is for me. I have to say that I have so many blessings to be able to work with brilliant women physicians, and every time I get to speak with Dr. Thakur and Dr. Bucci and Dr. Brooke Harris, I just feel so amazingly and profoundly fortunate. It is also mind-blowing to me that we went into this research study with the intentions of making profound change in the lives of children, particularly children that are low income and children of color. When you look at the scientific literature, it typically takes about 20 years for research findings to translate into real-world practice. And because of the profound power of this group, we actually have been able to make change on a statewide level and even internationally within the course of less than 5 years. In 2019, a representative from the Central Valley, Representative Arambula, proposed a bill to the California legislature. It was AB 340. AB 340 was a bill that was passed by both the California House of Representatives and Senate that recommended that all providers who see patients with Medi-Cal screen for adverse childhood experiences, and the recommended tool for screening is the PEARLS tool, the tool that we created, that we started working on in 2017. It is the only tool in the country. It is the only tool in the country for which providers are reimbursed for screening, and the only tool in the state of California that providers can get reimbursed. So I'm going to talk about how we translated the research findings into becoming the standard of care. As I launch into that, I want to share a personal story. I am the single mom of 3 boys. And my middle son, when he was turning 15, I had to take him to his pediatrician for a well child check. And he does not seek care in my University of California health system. We actually have Kaiser. So I was registering him at his Kaiser pediatrician office, and I told him, because I'm trying to teach him self-regulation and independence, to go and to let the registration clerk know that he was here. I was sitting in the waiting room, and he comes back with a stack of papers, and one of them was the PEARLS tool. And he looks at me, as 15-year-old boys do. "Ugh, Mom, what is this?" And I said, "Honey, we made this." And it was such a profound moment. I actually started crying, because to actually, this registration clerk didn't know that I was a co-principal investigator on that tool, right? And then he looks at me and he says, "Ugh, Mom, you're so cringe." So that kind of got me back to reality. It's really hard to impress our teens. So nonetheless, the rationale for screening for children, and this was put forth by the National Academy of Science, Engineering, and Medicine, it recommends the adoption of screening for trauma and adversities early in life to increase the likelihood of early detection. This should include rapid response and referral systems that can quickly bring protective resources to bear when early life adversities are detected through coordinated cross-sector expertise. There also is a recommendation that adults, as Dr. Thakur referred to, right, it's never too late, that adults are also screened for early childhood experiences because we can better understand how to treat mental and physical health by understanding the experiences of that individual. So this is the role of primary care physicians, but this extends to the role of Head Start teachers, right? It includes the role of anyone that touches the life of community. It's really important that we actually understand the science of ACEs and toxic stress and understand what the manifestations of that can be in terms of the symptomatology and physiology. We have to absolutely embrace this notion of trauma-informed care, which creates safe, stable places for families to come that build relationships and healing. We have to help our patients and community really understand the role of toxic stress in their lives. And I've been able to witness this in the exam room. I've been a pediatrician now for 23 years, and there's always this moment of quiet that I'm able to observe after a caretaker fills out the Pearl screen, right? I ask them, how was that for you? And inevitably there's this pause. And the responses that I get are, I wish someone had done this for me when I was a child, because every single one of these were positive. I wish I had known how stress is affecting the body of my child earlier so that I could make sure that I was being the best mom that I could be. Thank you so much for asking these questions. And I'm grateful that you asked, and I want you to actually do something about it. Right? We have a role to help families identify all of the great and amazing strengths. One of the things that we didn't have on the screen about the Pearls tool is that after gaining the experience from community with the tool, we actually added questions, and we added another part to the screen. And so that other part is about resiliency. Tell me something great about your child, and how did your family get through hard times? We also want to make the connection to families that the experience of discrimination and racism, for instance, it's hard, and it gets underneath our skin, and it can actually impact chronic illness. As we were wanting to roll out the Pearl screen through the Office of the Surgeon General and California Department of Public Health, we created this risk assessment algorithm based upon the research results. And what I really like about this algorithm is that when you screen, even if the score is 0, the algorithm leads you to really still talk about anticipatory guidance about how toxic stress can affect us and get underneath our skin, acknowledging that a score of 0 is not really ever a 0, that it really is about the trust and relationship that family has with us as providers, and that the next time they come in and get screened annually, that 0 might be a 4 or a 5. Intermediate risk is when you have a score of 1 or 2, but then it matters if there's actually health manifestations. And so if you have a score of 1, but that child has asthma or ADHD, it really does put them into a higher risk category. And then there's the unknown risk, right? So families just don't want to complete the screen, which we encourage that families have the ability to opt out. And even if that's the case, there should still be conversations about how we can actually mitigate toxic stress and improve health outcomes. Here is a list, and I know it's small, of ACE-associated health conditions. And stress affects us. It not only affects our mental health, but it also affects our physical health. And it ranges from everything from increased suicidal ideations and attempts to depression and ADHD to increased number of upper respiratory tract infections that a child might have per year. So the clinical response is varied, right? It's layered. It's everything from the way that the family is greeted when they walk into your organization. Do they actually feel welcomed, right? It's the acknowledgement that these ACE-associated health conditions might be the presenting complaint. Oh, he's not able to focus in school. He's being diagnosed with ADHD. But really, there's a lot of social adversity that's happening in his life. The response includes validating all of the parents' concerns as well as their strength and protective factors. Again, it's this question, tell me something great about your child, right? And the answers that we get range from, she loves to read with me, or I love that she always wants to give me a hug or a kiss, or that someone has a really close relationship with the grandparent, or they go to church, or they enjoy time outdoors together. We also want to make sure that we have what we refer to as these networks of care, right? Health happens in communities, and so how are you actually addressing some of these unmet basic needs? Do you have relationships with your library, with your food bank, with your WIC and your SNAP offices, with community-based mental health supports? And then ensuring that we don't let families fall through the cracks, that we actually are following up with families, and that it is okay to follow up as many times as we need to, and some of those follow-ups might be texts, or they might be telehealth, or they might be that you come and you actually see them in person, or that we go to their school. So there really are 3 guiding principles for the preventative strategies that are part of the response that we not only are studying, but we're recommending to others across the state. The first is that we want to support relationships, right? Early relational health is really the crux of all health. It's about attachment, and it's about love, and it's about trust, and providing safe, stable, nurturing relationships. The second is that we want to reduce sources of caregiver stress, and oftentimes it is stressful to be poor. It is stressful to not live in a good school district. It is stressful, all the community violence that's going on. And so recognizing what those sources of stress are and trying to actually do something about them. And then the third response is about strengthening capacity and skills for self-regulation, co-regulation, and mindfulness. We might not be able to make all the stress go away, but we certainly can actually affect our response to that stress. I spoke about anticipatory guidance in the algorithm, right? So even if your score is 0 or unknown, you still want to give anticipatory guidance, and as a physician, that's really our way of saying the preventative stuff that we talk about. So it could be potty training, it could be how to feed your child, it could be about reproductive health counseling, but the anticipatory guidance for toxic stress, we made up this acronym NOTE as part of our research study when we were doing the qualitative aspect and asking providers, what would you like to say to families? So the N stands for noticing the relationship, right? The relationships are the heart of our healing and health, and commenting on it. Every time she looks at you, she smiles, right? It's so important that you can talk to your auntie about anything. Who is your best friend? How often do you connect with them? Ask about relationships. The O is to offer the science, and it doesn't have to be complicated, right? Stress affects our hearts, our minds, and our bodies. It affects children just like it affects adults. It might look different, but it gets underneath our skin. When we ask families what do they want to know about the science, families are like, tell me everything. Like, why did I not know about toxic stress previously? There's often an assumption that our families won't understand or they don't want to know the science, and over and over and over again, that has been disputed. Families want to know. They want to know what's happening in their bodies and in the bodies of their child. The T stands for tools, and some of these tools are based upon trauma-informed practices of empathy, of just being able to listen and to sit in the uncomfortableness, because it's okay to be uncomfortable. It is okay for things to be awkward. It's about, can you actually sit in the middle of it and just be there to support our families? Other tools might include resources that you want to give, or it might be referrals and linkages to subspecialists and community organizations. And the E is for empowering, right? It's letting families know, I got you, I'm here for you. Anything you need, I'm here for, right? You can always reach me. There was a situation that I had when I was teaching a resident about this mnemonic, and she was very nervous. She felt scared because the family had just taken the Pearl screen, and she felt uncomfortable, like, what am I going to say? So I said, focus on NOTE. And she went into the room, and she came out, mind you, she's a very privileged white resident. This was a black family. There wasn't a lot of shared experiences between what this resident doctor and what this family was living. And she came out the room and she said, I said, how did it go? And she said, oh, the mom started to cry. And at first I'm like, oh no, like what happened? And so she said that she went through her note mnemonic and she told the mom, like, you're a really good parent. And she said the mom started to cry and said that nobody had ever told her that before. Right? Sometimes it's so simple. It's about showing up and being there and like making people visible. The Surgeon General, Dr. Burke Harris, before she resigned, she put out an exquisite roadmap to resiliency. You can Google it. It is like 400 pages. But one of the things in that roadmap to resiliency is this wheel. It's called the Stress Busters. And it is about what are the evidence-based strategies for mitigating toxic stress, and how can you promote regulation? So the wheel includes, again, relationships. It includes quality sleep. Sleep is so important, and I know there was a session earlier today about sleep. It's about balanced nutrition, but this is not about like balanced nutrition because we want to put patients on diets. It is understanding that food itself is medicine and that the food we eat can actually impact how our body is functioning. Physical activity, and that includes giving families tips about how to enjoy time together. And so it's going out in nature, right? Lots of studies that show that being outdoors around green space can lower cortisol, it can lower blood pressure. Or just turn the music on and take some time to dance around, right? Go on that walk with your dog or with your husband or your kid at night. It's about mindfulness practices, and I'm going to talk about this more. We just talked about access to nature and the importance of tending to mental health. One of my mentors, Dr. Alicia Lieberman at UCSF, who is the head of the Child Trauma Center, she taught me that you don't have to be a therapist to be therapeutic. So some of this tending to mental stress can happen in the primary care office. It can happen in community. Or if need be, it means that we need to refer people to psychiatrists and psychologists in order to get them some one-on-one therapy. When I spoke about the strategies, I spoke about reducing caregiver stress, and Dr. Thakur also touched on this, is that we have a program called FIND, which is the Family Information Navigation Desk, but it basically pairs community health workers, those that have lived experience, with families and ask questions about food insecurity, housing instability, the need for activities and childcare, the help with utilities such as, is the power on, is the water running, medical legal concerns around foreclosures, around evictions, around immigration issues. And then, especially during the pandemic, we did a lot of resourcing around making sure that kids had laptops and devices. Over and over and over again, studies have shown that working with navigators or community health workers actually reduces healthcare utilization, reduces ER visits, reduces length of stay, reduces admissions to the hospital. Our primary care mental health intervention was called the Resiliency Clinic. They were dyadic group visits that paired nurse practitioners and mental health clinicians with families. Initially, it was in person. We moved to a virtual model. And the tenets are about mindfulness, self-regulation, and co-regulation, as well as intermixed science around toxic stress and how it affects our body. Families have loved those resiliency clinics. We have based them upon age and affinity. And so we have a Spanish-speaking resiliency clinic, we have an English-speaking resiliency clinic, and then it's broken down by age. So initially we had like a 0 to 2-year-old and then a 3 to 5-year-old. The feedback that we've gotten from families is that they love those resiliency clinics. It was the social networking that was really helpful. And our preliminary data does show that these types of group visits have reduced caregiver stress significantly. We also have behavioral health integration, so we have co-visits with our mental health clinicians. We have a medical social worker who can help us if there's sort of escalated concerns. And we have a list of our community-based mental health organizations that we refer families to. So much of providing safe, stable, nurturing relationships is about supporting the capacity of the caregiver to be a buffer for that child. And so we really want to focus our interventions on raising the caregiver's awareness of their own capacity to self-regulate. For those of you, I don't know how many of you have done Circle of Security, but there's this notion within Circle of Security parenting that you always want to have literally a picture of hands, right? Like you always want to have your hands open for your child so that you encourage them to go explore the world, and then you welcome them back with open arms, open hands, and it encourages this sense of wonder and curiosity and really just delighting in your child. We also teach families about the ability to support them in helping their child learn to self-regulate. And so some of the ways that we do that are we create these glitter jars. I love glitter jars. I had one on my desk before the pandemic, and I'm actually thinking I should make another. And so a glitter jar literally is a jar that has some water, some soap, and a whole bunch of glitter. And that when the child is feeling really activated, right? They can shake up the glitter. Their emotions are like the glitter that's swirling around. And then as the glitter settles, they kind of settle themselves. Other really easy activities are like breathing exercises. So 4-1-5 breathing, right? You breathe in for 4, you hold it for 1, you breathe out for 5. And then we have this other great activity where they learn to name where the anger is in their body. And so we had a young gentleman, he was 6, and he was getting into a lot of fights in school. And so he did this activity, where do you feel the anger? And he said, I feel it in my hands, and then I hit, right? And so then the question for him is, when you feel it in your hands, right, what else can you do? Right? What else can you do with your hands, right? Is it that you can fidget with something? Is it when you feel it, you take a time out and you ask to go for a walk or to be excused from class? So this process of co-regulation can really help a child develop their own ability to how they respond to stress in their life. Besides supporting clinics like across the state of California, we are also affecting like policy and the ways that our state is responding to ACEs. And so we have this now multi-center, starting in 2019, multi-center initiative that is between UCSF and UCLA that is helping us to support the raising of awareness and clinicians across the state in order to screen for ACEs. And on the research front, there are so many more questions that we want to ask, right? We know that our health system needs to change to be much more responsive to families, much more trauma-informed, much more equity-based. But we want to continue to study this. We want to know, are we asking the right questions about trauma and unmet basic needs? What really are the most effective, most cost-effective interventions? And how do we actually identify kids who are high risk for potential poor health outcomes from ACEs exposure? And then how do we screen for these protective factors? All of these questions led us to be granted by the governor of California, Governor Newsom, a California Precision Medicine Award, which we currently are working on, in order to answer a lot of these questions. And so our current study is called CARE, the Collaborative Approach to Examining Adversity and Building Resilience. And it's a partnership not only with UCSF and our Benioff Children's Hospital, but also with a community clinic in Richmond, California called Lifelong Clinic, a clinic in Santa Barbara called the Santa Barbara Neighborhoods Clinic, and an organization called Futures Without Violence, and their whole goal is to prevent child abuse and trauma. And so our California Precision Medicine study, the CARE study, has 3 main aims. For our initial PEARL study, we recruited 555 families in order to create the tool to create correlations between trauma and adversity, and do the statistical validation that we need to actually prove that this tool is feasible for screening kids. We now are taking that cohort, that 555 kids, and actually studying them longitudinally. We are now on year 5, and we want to continue to know, like, what is the accumulative effect of trauma on kids' health, and we want to be able to examine better how protective factors can actually modify the toxic stress response. Another part of the study is really figuring out what interventions are the most effective for responding to trauma. And this is not just within our little children's hospital anymore, but we're replicating this type of dyadic group intervention, both in Richmond, California and in Santa Barbara. We're trying to figure out what is the dose response of intervention in order to improve outcomes. And then the third aim is this resiliency toolkit. So how can we better teach your organizations in order to do the work of screening and responding to ACEs? So the governor of California said that decreasing the burden of ACEs is not only ethical and an ethical and moral imperative, but it's critical to our economic vitality. This work is a key preventative measure to improve health and societal outcomes for our state's residents for generations to come. We have a big, bold vision for the state of California that we want to reduce the exposure to ACEs in half by 1 generation. The way that we're going to get to that goal is through the work that we're doing for this network across the state. It's called UCAN, which is the UCLA UCSF ACEs Aware Family Resilience Network. Like I said, it was launched in 2019. It's funded by DHCS and OSG. And our goal is we have 3 main goals, right? To develop, promote, and sustain evidence-based methods to screen for ACEs, to bring communities together to create these networks of care, and to leverage academic and community resources to really transform clinical practice through quality improvement, training, and technical assistance. So again, our goals are raising awareness. We are training thousands and thousands of community members, of pediatricians on a monthly basis to become ACEs aware. We are giving grants to health systems and community partners in order to create these practice of changes. We've given out about $65 million to community-based organizations to start to do this work. And we really want our health systems to start working with Medicaid, to start partnering with community, so that there's never a wrong door for families. We started to look at claims data across the state, and so just from January 20th to March 31st of 2022, so this is like right during the pandemic, we have already screened across the state. We have performed 1,334,000 screens across the state of California, and this number is just increasing basically every day. So it's really profound change. If any of you are interested in becoming ACEs aware to take the training, it's free. Here is a code that you can scan. There also is the website that you can go to in order to get trained. If any of you are working within health systems, oh, yes. Woohoo, this is so exciting. I would love if at least, those of you that are scanning it, if at least 75% of you ended up taking the training, that would be so awesome. I also just want you guys to know the law, and the law is that any Medicaid provider can get reimbursed from the state of California for screening. It doesn't matter what kind of clinic you're in, if you're recognized as like a fairly qualified health center, or if it's just a community clinic, or if it's Kaiser, right? As of July 1st of 2020, any Medicaid provider that's taking the training can get reimbursed for doing the screening, and providers have to attest to that screening. I'm hoping that we can get you guys copies, but this is where you submit your attestation in order to get paid. So again, I want to thank my amazing colleagues and all of our partners that have helped bring us to this point. So that includes, again, UCSF Benioff Children's Hospital, the UCSF School of Medicine, the Center for Youth Wellness, and some of our funders. So we're happy to take questions. Thanks for hearing us out.
Go ahead.
You mentioned earlier there was a correlation between these sort of traumatic experiences, childhood, and medical conditions. As those Oh, okay. Hi. So I was wondering that you mentioned that there was some sort of correlation between some of these traumatic events or these hard childhood events and actual physical health issues. And I was wondering that if these problems get alleviated or they receive, or these people who underwent those sort of experiences receive some sort of therapy or treatment, do those medical conditions kind of lessen in harshness? That makes sense?
Yeah, no, 100%. We come at this work with a resilience mind. So we don't come with this as, oh, if you've experienced trauma or if you live in a neighborhood that has a lot of exposures to stress and violence and other factors, that your health as you get older is doomed to be bad. There is good evidence, as Dr. Long pointed out, that if you that these effects can be buffered. They can be buffered by having a positive relationship with an adult in your life. They can be buffered by going out into nature. They can be buffered with exercise. They can be buffered with sleep. But we need to prioritize these things and make sure that people are able to access this. And then for relationship building, we need to be sure that people have those resources on how to build those positive relationships. So it's absolutely preventable.
Hi, I'm Eloisa Junqueira, pediatrician locally. Do you know if any counties, on top of using pearls, if any managed care medical programs are offering any kind of programs for to acting on the result of the pearls with the family? Are they offering any community programs, or are they offering any training for providers, or are they doing any kind of work about that?
So I don't believe that, if your question is Medicaid offering programs, I have not heard of programs through Medicaid per se. However, DHCS is doing a lot in order to support communities to address ACEs. I want to point you to the ACEs Aware website. There are so many tools on that website in terms of training physicians, but also grant-making opportunities and examples and case studies of the ways that individual clinics are sort of creating these networks of care.
Anyone else? We may have time for one more question, and then we've got to. Oh, okay. Oh.
I love what you've done with the ACEs, and I think this is fantastic. I just had one question, though, about, like, you know how out of the 10 different things in the ACEs items, you know, the physical violence that you ask the parents about, I don't know that they can trust you with that because, you know, as medical people, we're mandated reporters. So how did you handle that? And did you have to make CPS reports? And did they keep coming back? Or did you help those kids not get violently hurt at home? Did something happen with that?
I think we both can. So this is such a great question, and I feel like that's what you just said is really the thing that keeps clinicians from actually screening, right? It's this fear that what happens if it's positive? What am I going to do? How am I going to support the family? I want to respond in terms of what I've noticed, the data from the research, but then also what I've noticed in clinical practice, and then the third layer is the conversations that are happening on the larger state level. In our sample of families, all of them were screened with pearls. What we found is that of all the hundreds of patients that we screened, there actually were 5 CPS reports that from that population of kids. Of those 5, only 1 was a totally new, surprised the pediatrician, didn't know it before. Those other cases, 3 of them, the CPS report was it had already been made previously. In one of the cases, the pediatrician was already planning on contacting the medical social worker because she already had concerns, like the pearls tool didn't influence her in any way. She already knew that this was an issue. And then there was only one case where the pediatrician was really surprised that was the situation of the child. So statistically, it didn't really increase the amount of CPS reporting from my clinic. And that one situation, the kid was in an unsafe space, and it kind of needed to happen. From a clinical perspective, I think because that's the biggest fear, a lot of clinicians are hesitant to screen, and then they start to screen and they realize how much closer their relationship is with their family, how much more trust that there is, that they had wished that they had started to do it sooner, and that the family actually feels like that pediatrician is invested in their health and their well-being. There are conversations on the state level about this exact issue, and we actually in May are hosting a webinar about CPS reporting. You can find out more about it on the ACEs Aware website, but this is definitely a hot topic, and my own clinical experience is that this hasn't been an issue, and when it is, it probably needs to be an issue.
Thank you. Go
I'll
ahead,
just
Neeta.
follow that up. We actually designed the tool in a way that discloses to the family the need for disclosure. Like we have that up front in the intro message saying that some of the things that you may share may result in a reporting, which is why we allow families to opt out of the tool. And then the second is that when the questions are asked in aggregate form, they could be reporting many different things as a positive score. And so we wanted to create a way where the pediatrician or the provider that's asking the ACEs didn't have to respond in the moment, but needs to make space to find out what might be driving the scores when there is a time to be able to respond to the family. And so we did leave some flexibility, knowing that that was a big concern, both from families, but also from practitioners.
Thank you so much. Can we get a round of applause for these three doctors?